So I asked probably about 6 fellows what case they would like to see. And we kicked back a number of cases. There are a lot of great opportunities here to show teaching points, et cetera. And the fellows selected this case. So I think they wanted to see more of MCS type stuff. So I also titled this a little bit differently. I said one of our best saves. So I think it's important to highlight that we have a lot of saves to talk about. And also to highlight the word our instead of my, because this is a team approach, and we can't do this in isolation. So this is a 70-year-old gentleman who presented to an outside hospital with an inferior STEMI. He presented 18 hours after symptom onset. And at the time of presentation, his blood pressure was 110/80, heart rate 90 on cath lab arrival. You can see the angiogram there from the outside hospital. He's got some LAD disease. He's also got a thrombotically occluded RCA with some filling in this collateral to a distal RPDA. The team there went ahead and did PCI of the RCA, 4 overlapping bare metal stents, distal RPL, and RPDA had a lot of thrombus burden, as you can see. Blood pressure at this point, though, started to become a little bit more hypotensive, 80/60, heart rate still now up to about 110 post-PCI. And so the question for anybody who's dealing with these types of cases is now what? So the team there elected to put in an intra-aortic balloon pump, and they also intelligently elected to put in a right heart cath. So the right heart cath, the data is there for you. So the RA pressure is 18, the PA pressure is 34/28, the wedge is 18, the mixed venous sat is 38%, and this is on balloon pump support. So they calculated a cardiac power output of 0.42 and a POPI of 0.3. And the echocardiogram at the time showed a moderate severe RV dysfunction and EF of 40%. So what would people do at this stage with this type of case? Okay, so good, I guess, maybe.
Improving coronary flow.
Improving coronary flow, okay, so how would we do that?
Can you aspirate those clots?
So you can see the angiogram on the left, that's the residual and the post, so there's still certainly there could be more work to be done. This is 18 hours post-presentation, so the likelihood of getting a fresh clot out is starting to become more diminished.
It looks like they've jailed off all the RV marginals, from that
Critical.
right, which I think really this is predominantly right-sided.
Yeah, so this is a really critical point that once you lose those marginals, that's when you start to develop RV free wall dysfunction.
So,
Okay, so we've got a balloon pump, you've got these hemodynamics, and so we've heard about bipella. What else could you do for this gentleman? You could do a septostomy, which is a very interesting concept. So septostomies, I think it's an important point to bring up. So these are passive pop-off valves for the right atrium. Your RA to wedge pressure ratio is 1. So now the question is, you create an intra-atrial septostomy. You've got basically now sort of equipoise on the flow. So you could do a tandem, right, and unload the left side. You could do a tandem and do the right side. So BiV tandems.
And you're not, I guess I would be looking more towards right-sided support and thinking about RP or a duotech or something like that.
Okay.
Because I'm not totally convinced, well, we're not on dobutamine yet,
Yep.
It's predominantly an RV failure.
Yeah.
So
Okay.
I think before we had hemodynamic support, not too long ago, you'd be using some sort of RV inotropic support, and I think now we have right ventricular pump support.
Yeah.
That's what I would be thinking of.
Okay, so if you don't have RP at your site, it's not available.
ECMO could be considered.
Yeah, so ECMO, right? Okay, good. So you've got all the options in front of you. You guys are making the right decisions here. So this team didn't have RP on site, and so they decided to go with ECMO. So they initiated VA ECMO, 29 French venous inflow, 17 French arterial outflow, IABP 1:1, 4,500 RPMs, 4.7 liters per minute of flow, which makes us all feel better. The map comes up, which is always good, to 80 to 90. The patient's actually extubated in 48 hours, which is good, and they're unable to wean VA ECMO. So every time you go on VA ECMO, what you want to do every morning is a turn down, and you want to see what the native ventricular function looks like, especially in the STEMIs where you're looking for recovery. So this is actually the echo during a turn down. So this is with minimal flow through the ECMO circuit, and now you've got pretty profound biventricular failure in this gentleman who's on VA ECMO. And so the question is, now what? Okay.
BiVAD to recovery.
Okay, so surgical BiVAD, right?
Unload the ventricle with impeller.
Yeah.
Okay, so you've got a balloon pump in, right? So supposedly that should be venting, but you could upgrade. There's no septostomy at this stage, no? So you could do, again, as Maurice had indicated, this idea of a passive unloading with a pop-off valve. Okay. All right, good. So those are the things to think about, is try to unload the left side and try to get biventricular support using a VA ECMO configuration. So the patient is transferred to Tufts for advanced heart failure BiVAD, so surgical BiVAD, and transplant eval. And so we accepted the patient. I was the transplant doc on service that week. So on arrival, the patient has severe pulsatile bleeding from the IABP site, in transport, et cetera, who knows. And they're on full anticoagulation on VA ECMO. MAP is 100, heart rate's 90. These are the hemodynamics. RA is 8. The PA pressure 20/14, mixed venous sat of 63. So we said, okay, let's take the balloon pump out. It's bleeding. So we're at the bedside with the fellow holding pressure, and as soon as we take the balloon pump out, we develop polymorphic VT. So now we're having recurrent VTs in and out on his own. He's required a couple defibrillations at this point. You're now in the unit. You've accepted this patient for BiVAD eval. So now what?
Take it back to the lab. I think the right's down.
Okay, so go back to the lab, see if the right's down. Okay, what else?
He's on full support, right? So he's not hemodynamically unstable.
He's on VA ECMO, right? So he's going to tolerate VF to a degree. And you can see here, even in some of the data up at the top of the screen, you can see our arterial mean pressure is 69. So his MAP went from 80 to 90 down to 69 while he's in VT. Okay, so you could still think about whether to unload the LV. Now with VA ECMO and polymorphic VT, the main question comes up is, why is he going into VT, right? So is it that the ECMO circuit without the balloon pump is now distended the LV? You've got significant wall stress in an ischemic substrate. Is it the RCA is shut down? Is it that the LAD itself, which was 80% stenosis and unrevascularized, is that causing a problem? So those are the questions. So the correct answer is, as you said, is to go back to the lab for further interrogation. So we bring the patient to the cath lab, and the question is this LV distension or is this LAD ischemia? So the quickest way to sort this out is to put in a LV pigtail catheter and take a look at the tracing. So if you look at the diastolic tracing here, what you see is a very nice flat diastolic curve, right, which tells you that this is not due to massive loading of the ventricle. This is not due to high wall stress. This ventricle is pretty well unloaded, not bad. And you're looking at the PA catheter numbers in the setting of recurrent VT, RA pressure of 10, wedge of 12, and mixed venous sat of 45%. So not due to LV distension. So the polymorphic VT most likely is due to ischemia. The RCA stent's wide open. And so the question is this the LAD? And remember, every time they tried to turn down ECMO, the anterior wall became hypokinetic. They couldn't get him off ECMO. So at this point, what we said was, let's change out. So we lost our vent, which was the balloon pump. So we, at that point, put it in a CPE. The cath team was told that this is going to be a high-risk PCI because we're going to do the LAD on ECMO. So for the high-risk PCI protocol, they go to P8. And so while we're getting the Impella in up at P8, this was the tracing activation at P8 on VA ECMO. So what's this? The aortic valve is closed. So as soon as you activate CP at P8, you're seeing that you've gone from this respiraphasic amplitude, and then you start to see this, which is a classic unloading of the Impella. But then you see this. So what is that? What is that? So it's an LV pressure of negative 50. Okay, so the VA ECMO is draining as much venous preload as possible. Okay, so this is the hemodynamic signature of an LV suction event. And so what you'll see on the Impella, and the Impella alarms all the time, suction event. But actually, when you see this is actually true suction. And in the OR, the surgeons, when they see this, they see actually the ventricles basically collapse when they're going on LVAD and they get suction events. But this is a critically important point, especially for anybody who's managing these pumps, is that when you are using a CP as a vent, you really should be running it at P3. It's not meant to be run at P8 as a vent. The only thing you're going to do is drive hemolysis and cause suction events, which will trigger more VT. And so you're going to work against yourself. So that's the hemodynamic tracing of suction event. So the CP was put down to P3, P4, and that's important to remember that they're preload dependent. So if your VA ECMO is draining the RV, you're not going to have that LV preload as much. And so a not so complex LAD PCI was completed. We took care of this LAD in a couple minutes with the CP in place. And so now post-revascularization, we're able to do an ECMO turndown. So now that the LAD has been taken care of, we're able to do our weans. It comes off the VA ECMO circuit pretty quickly. 3 days later, the CP is now converted to an axillary 5.0 because he still needs LV support. You can see this echocardiogram of us with the turndown. The LV is not happy at this point. So we put in a 5.0, which allows us to take our gentleman and ambulate him and work with him for rehab. So he's on the ECPella configuration for 1 week. He does the turn down, ECMO decannulation day 11. CP is removed. He's upgraded to a 5.0 through the left axillary. And he's on the Impella 5.0 for 5 days. His LVEF improves to 40%. RV actually normalizes, and these are his hemodynamics on P3 with the 5.0. He's completely normalized his hemodynamics at this point. So the 5.0 is removed. He's bridged to recovery, and he's doing well at 7 months follow-up. And so the idea here is this concept of bridging to recovery. And so what you'll start to see more over time now is quantifying ambulation amongst patients who are getting axillary CPs and 5.0s. And it turns out that if you actually look at a Hopkins mobility score and you can actually get your patients up and walking around with an axillary CP or 5.0, and you get to a level of 10 steps or 25 steps or greater, these patients are more likely to survive with their native heart. So keep in mind that this patient was referred for surgical BIVAD or transplant and actually went home and kept his native heart. So take-home messages for the team is evaluate all patients referred for advanced heart failure therapies for coronary revascularization. The turndowns are critical to tell us what our next step is going to be. Let the hemodynamics guide your decision-making around the use of support. And then employ acute MCS to support that high-risk PCI, especially even in patients with ECMO. You should still be thinking about that LV support strategy. And then complete revascularization or LV unloading are key. And, of course, engage your heart failure colleagues because these patients require a lot of thought and processing. Thanks so much.
That was super. Any questions before we?
Yes. The Impella CP 5.0 was switched for more support, or you just wanted to switch from femoral to axillary and uterine?
Yeah, so it's actually a little bit of both. So the CP itself, is fine, and we've left CPs in for days. The problem is when they're doing a femoral deployment in a guy who we're trying to get and recover, we've got to switch it over to an axillary. And if we're going to do axillary, especially in these patients who are still on that marginal EF and haven't fully recovered at that point, those patients will put in a durable 5.0, which allows us to do it through a vascular graft. We've definitely done CP through punctures and through non-surgical grafts approaches, and those you can also ambulate. But usually with these types of patients, we like to give them at least potentially up to 2 weeks, 3 weeks of support, and that's where we'll convert over to a 5.0. Yep.
Just a couple questions. So in this case, the patient had symptom onset about 18 hours prior to arrival. How does that time from their symptom onset affect your decision about whether you should put a support device first for going towards PCI? Let's say they were kind of showing mild type of shock, cardiac shock upon arrival. And then what if they're, let's say they're coming from an outside hospital and their time from first medical contact to device time, let's say, could be longer than 120 minutes or something like that. How does that change what you do first?
Yeah. Yeah, so really great questions. I think this gets to the point of the idea of still stratifying the magnitude of shock that you're dealing with and the type of shock you're dealing with. So this is an RV infarct. It's Prox RCA. And so those patients actually tend to do pretty well for the most part. And in fact, the RV has a great tolerance for that type of insult. So as long as the patient arrived normotensive and actually did well until the reperfusion phase. And so I think that's the most important point for the upfront decision making. I think there's no need in this particular case to start the patient on mechanical support. They're not on pressors. They've got a good blood pressure. It's a Prox RCA occlusion that's going to be taken care of. The decision making starts to accelerate once you start to see that hemodynamic compromise. And there's no question that the more delayed presentations for STEMI are the ones who are more likely to progress into a hemodynamic decompensation. So I think the idea of doing this in terms of transfers and how to get patients on support really depends on the type of patient you're dealing with. We're not at the phase, as you heard from the discussions earlier today, where we would start putting everybody on an unloading support device just for early phases of shock with normotensive shock. That's really starting to split hairs. So I would still at this point wait until you've got bona fide shock before you actually start looking at support before reperfusion.